update on dengue and dengue vaccine. It's a huge topic, but I will try to cover it within the allotted time. And as you know, as per the Lancet, this dengue is one of the fastest spreading infectious disease, and nearly half of the world's population live in the dengue endemic area. And nearly there are 25 lakhs cases with 2,065 deaths across the globe, and the major contributor Brazil, Vietnam, Philippines, Indonesia, and Peru. At the same time, in 2022, India also records a very significant cases as far as the dengue cases are concerned, and that is especially in the post-COVID area as well. And if we look at the seroprevalence, as per the dengue in the SARC territory, the latest report in 2022, dengue 2 virus is the major prevalent serotype over last 50 years. But what has been changed is that now dengue 1, dengue 3, and dengue 4 are also picking up, and there is a co-circulation as well. And because of this change in the seroprevalence, there has been a significant change in the dengue associated clinical manifestation. Majority of the liver enzymes are affected very adversely, and that the leaky phase is going to be a little more longer as compared to previous dengue cases that we are observing over the decades and years. And as you know that there are 4 different serotypes of dengue, and infection with any one serotype will give a lifelong protection, but it will not give cross protection to the other dengue virus. And therefore, when there is secondary infection with heterologous serotype, there is a mechanism which is described as antibody-dependent enhancements. And this ADE, along with the cytokine storm, will lead to severe thrombocytopenia, capillary leakage, and sometimes it may cause a life-threatening complication and death as well. But what is important that I want to emphasize that what is the similarity or the dissimilarity between the COVID and dengue? So it is very, very important that both the disease, that is COVID-19 and dengue, will have antibody-dependent enhancement. Both can have cytokine storm. Both can have vasculopathy, and both can have coagulopathy. And therefore, in an area where the COVID pandemic is going on, and when the dengue outbreak is going on, probably as a clinician, we are often perplexed. And therefore, what is common to both clinically is that a short febrile illness with fever, leukopenia, and thrombocytopenia. But in COVID, most of the time, the respiratory symptoms are more common. Retrobulbar pain, body ache, rash, and bleeding manifest, especially petechiae, is common found with the dengue. But remember that dengue is a disciplined illness. Dengue is a disciplined illness, whereas as far as the course is concerned, COVID is concerned, it's quite uncertain, especially in a child who is obese and with a comorbid conditions. And therefore, when there is a fever, diarrhea, headache, chest pain, myalgia, orinophagia, arthralgia, and when the respiratory manifestations are not there, we are often difficult to find out whether we're dealing with a COVID or dengue. And therefore, extrapulmonary manifestation of COVID-19 and dengue co-infection is also there, that has been reported in the literature as well. We also know this new classification, the dengue with warning sign, dengue without warning sign, and I will not go much in the detail because to another time, but any child who has the probable dengue will require a OPD treatment. Child with warning sign, that is abdominal pain, persistent vomiting, clinical signs of third spacing, mucosal lethargy, liver enzyme and rising hematocrit, falling platelet, these are the cases we need to be admitted. And child who has a severe dengue, that is shock, respiratory distress, severe bleeding, or organ involvement, AST more than 1,000, they require ICU admission. As far as diagnosis is concerned, it is always the epidemiological background is very important. At the same time, a clinical pattern that I have already described, CBC, that is rising hematocrit, falling platelet, NS1, serology, PCR. These are the various modalities that are available. But most of the time, dengue is a clinical diagnosis. NS1 is a foolproof, nearly 100% specific, but negative NS1 does not rule out dengue. At the same time, if NS1 which is persistent beyond 4 or 5 days, usually the dengue is going to be a serious one. Similarly, the IgG and IgM, By the time they appear by day 10, usually the clinical course often becomes obvious. Either the child will have gone into a shock or the child would have recovered. So what is required is the clinical parameters, epidemiological pattern, and the serial hematocrit. That is very, very important as far as the diagnosis and monitoring case of the dengue is concerned. As far as monitoring is concerned, once the case is diagnosed, it is a clinical, and clinical, nothing else. So temperature, tachycardia, narrow blood pressure, cold extremities, these are the signs of that the child is going for a dengue shock. Remember that USG can detect the plasma leak earlier than the rise in the hematocrit value. Similarly, appearance of the tenderness in the hepatomegaly, edema, mental status, respiratory distress, diminished urine output, these are the findings which suggest that yes, this child has got a severe dengue. When you're starting an IV fluid, when the hematocrit is rising and the child is still unwell, the child needs the fluid. But if the hematocrit is falling, and in spite the child is not doing well and deteriorating, probably that there must be some internal hemorrhage. So this is very, very important that rising hematocrit in an unwell child requires fluid, but falling hematocrit in an otherwise undeteriorating child, that you have to suspect that internal bleeding might have taken, and probably the child may require blood product. So most important for preventing morbid mortality is a serial hematocrit, and do not withdraw the fluid therapy pending the laboratory report. Now it is very important for all of us to find out that whether we are dealing with a shock or not. And for that, any child of a dengue who has got a sweating, abdominal pain, restlessness, altered conscious level of sign, cold extremity, prolonged capillary refill time, more than 2 seconds, these are the cases which require to look for the shock. Similarly, unexplained tachycardia, increasing diastolic pressure, narrow pulse pressure, and unexplained leukocytosis. So when you're doing a serial CBC, if there is an unexplained leukocytosis, probably in a child who is deteriorating, if the hematocrit is falling, probably we are dealing with a case of internal bleeding and the child is going for the shock. Now this is the typical algorithm. I may not go into this. This is the algorithm for the complex shock, where we start with the fluid that is 10 to 20 ml, and then they will decrease, titrated as the child is improving. And this is for the hypotensive shock. Again, this is, I'm not going to detail this because it's available in all the textbook. But as an update, what I'm going to present to you, that this is the fluid therapy, that is the current concept. And therefore, both oral as well as IV fluid should be considered as per the ideal body weight or the actual body weight, whichever is less. If the child is more than 50 kg, it should be treated as an adult individual. See, and for the entire critical phase, irrespective of the length of this critical phase, the amount of fluid required is maintenance plus 5% of the body weight, that is 50 ml per kg, to maintain the perfusion of the vital organs. And at the same time, when there is a guideline for the fluid critical phase, without shock, remember that the fluid requirement is now less and less. Now we are starting with 1.5 ml per kg, not the 3 ml per kg, gradually increase to 7 ml per kg. And once the child is doing well, gradually coming down. So within 48 hours, the fluid requirement will be less and less, and the target urine output should be 0.5 to 1 ml. Remember, if the urine output is more than 1 ml per kg, you are doing a fluid overload. So the target urine output should be 0.5 ml to 1 ml per kg. So now we are opting for less and less fluid as far as the dengue management is concerned. If there is no response to this, then again back to the basic. You have to look for the ABCS, that is acidosis, bleeding, calcium, and sugar. So you have to must take. So do not just go on pushing the fluid. Look at the other metabolic parameters as well. That is acidosis. There may be some internal bleeding. There may be hypocalcemia, or there may be hypoglycemia. Similarly, colloids are required only after the failure of the tuberculosis, or when the shock is there in a child who is otherwise loaded with the fluid. And for that, dextran or starch can be used, but never used FFP as a bolus as well. Blood products, that is PS, is required only in case of internal bleeding. Platelets are not required unless you are going for some procedure or some central line and the platelet is less than 50,000. Similarly, inotropes are not required. They give a false sense of security, and usually CBP monitoring is required when you are going to use the IV. But I want to emphasize that always go, if the facet is available, always go for the functional echo and look at the inferior vena cava. If the inferior vena cava is collapsed, child requires more bleeding. If the infection of KY is full, probably child does not require. So functional echo is very, very important. And these are the discharge criteria. When there is no fever for at least 24 hours, at least 2 days have left after the recovery from the shock. Child condition is good, appetite is good, hematocrit is near normal or around 38 to 40% when baseline is there, and platelet count is definitely above 50,000. These are the criteria where discharge is there. And our own experience in the post-COVID dengue cases, in nearly 80 cases, the common age group was 5 to 14 years. A younger age group are no more affected. We have 2 cases below 1 year, youngest of 7 months, which was not having fever but have a very serious course as far as dengue is concerned. Elevated enzyme in thousands are common nowadays. Second phase is more prolonged compared to previous dengue illnesses. CNS complications, including Guillain-Barré, we have seen in two cases, and we have seen lots of hyperferritinemia as far as the dengue cases are concerned. And those children who have got severe dengue, they have a ferritin level was very, very high. So that is all about dengue. As far as vaccines are concerned, it is a need of the hour. Why? Because the dengue outbreaks overwhelm the healthcare system. There are no specific dengue therapies available, and there is a great pressure in endemic area for a dengue vaccine. And as you know that there is no lifelong homotypic protection and there is no cross protection, and therefore there is a need for the broad spectrum tetravalent vaccine. As far as the vaccine is available, there are different live attended vaccines are available. That is, one is from the Sanofi, that is CYD TDV, other is Tetravax, that is TV003 and TV05, and other is tetravalent dengue vaccine from Takeda. So out of this, the vaccine, the whole list there, only 2 vaccine has passed the phase 3 trial. That is a CYD, the dengue vaccine license, but the post-license evaluation is ongoing and has been already withdrawn from the from India market because of this side effects. And other is the Danvax Tech 03, again a live attenuated vaccine that is in the phase 3 trial, and other is the Tetravax DB. So these are the vaccines which has entered the phase 3. Other vaccines are in the either in the phase 1 or phase 2 trial. As far as the dengue vaccine from Sanofi is concerned, is a live chimeric tetravalent vaccine administered in 3 doses. That is dose 0, 6 months and 12 months. Is a very long duration of the steroid as far as the vaccine is concerned. First license in Mexico in December 2014, commercially available in Philippines and Indonesia in 2016, and registered in more than 20 countries. But registered more than 20 countries and substantial public health program in Brazil and Philippines. So majority of doses has been used in Brazil and Philippines. But what is important that this vaccine has a rapid fallout, because it is a very low efficacy as far as the younger children is concerned. In children between 2 to 5 years, the efficacy is nearly less than 33%. There is increased risk of hospitalization, severe disease, and death after the dengue vaccine. So the safety issues are always there, and the dengue is found to be more effective and seropositive, and was not effective or efficacious or immunogenic in an immunologically naive patient. And so, as far as the 211 serious cases with dengue vaccine is concerned, 87 cases had a dengue fever, 14 cases have a fatal outcome out of 87 cases. So, this dengue has the number. So, the limitation with dengue vaccine is that there is poor efficacy in younger children, poor efficacy in seronegative children, less immunity for dengue virus 2. There is safety issue, high chances of dengue hemorrhagic fever, and even death following the vaccination. And there is a long dosage schedule that 3 doses require as long duration as 12 months. And therefore, we need to have a very important ideal vaccine which is useful in children, safe, effective, even in the seronegative children. It should be a broad spectrum covering all the 4 dengue viruses, short dosing interval, and fast onset of action. And a new vaccine, that is Takeda, is a row of hope at the end of the dark tunnel. Again, it's a live attenuated vaccine. And as far as immunity is concerned, it creates neutralizing antibody. It also imparts cell immunity. It imparts antibody to NS1 as well. And the 2 doses are given here instead of 3 doses, 3 months apart, and single dose is also being under evaluation as far as this vaccine is concerned. This vaccine has been deeply studied in nearly 20,000 participants. And if you look at the efficacy in a tight study, that is vaccine efficacy of 62% against all viral confirmed dengue cases, 65% vaccine efficacy in seropositive individuals, and 54.3% vaccine efficacy in seronegative individuals. As far as the hospitalization against dengue is concerned, the vaccine efficacy is 86.3% in seropositive individuals, and in seronegative it is nearly 83%. So the vaccine is effective in all the age group, irrespective of seroprevalence. The rapid onset of action is also there with this Takeda vaccine, that is 97.7 efficacy against type 3 after one dose, 73.7% against type 1, and 63.3% against type 2. So the vaccine has also a rapid onset of action as well. As far as safety is concerned, it is generally well tolerated and there were no important safety risks concerned. There is no evidence of disease enhancement or antibody-induced enhancement as the vaccine is concerned. So the vaccine is very, very promising. And if you look at the 4.5-year study of this Takeda Tide study, the tetravalent against dengue vaccine is there because the safety and efficacy has to be obtained for considered 3 to 5 years as per the WHO recommendation. And this vaccine has proved his credibility, that is that 84% prevention of the dengue hospitalization, 61% prevention as per symptom dengue is concerned, and overall the vaccine is found to be safe and also effective in seronegative cases. So, but in spite of this, all this safety and efficacy, this dengue vaccine has not been licensed anywhere in the world. The only recently in August 2022, Takeda dengue vaccine has been approved by Indonesia for the age of 6 to 45. So in spite of all these credentials, the vaccine is now started approved in Indonesia. Otherwise, it has not been available, approved anywhere. As far as Indian scenario is concerned, we are working on 2 different vaccines. That is Tetravax dengue vaccine, a live veterinary vaccine licensed from US NIH to Indian Pfizer company, and DS4 indigenous subunit protein vaccine. However, none of these vaccines have started even their phase 1 trial. So what is future is that the Takeda will seek an indication for TAC 003 for the prevention of dengue vaccine in individual 4 to 6 years of age, regardless of the previous virus exposure, based on the data in both adult and the children. And there remains a need for the dengue vaccine that can be used in both dengue naive and dengue exposed adult children. So thank you very much for sharing.